Okay. Good morning, everyone, and thank you for joining me today. My name is Dr. Thanyapon Hengpongthorn, and I work at the Geriatric Excellence Center here at King Chulalongkorn Memorial Hospital. Today's lecture is titled Common Bowel and Bladder Problems in Older People, and we're going to spend our time together talking about the two conditions that are extremely common in the older population. There are urinary incontinence and constipation. Before we dive in, let's set out what I would like to present. First, I will describe the definition and the different types of incontinence and constipation. Second, the physiologic changes that happen with normal aging, and then describe about a clinical approach to an older people with these two conditions. And finally, you should know about the basic management principle for both conditions. Here are 4 objectives of today's lesson. Okay, we are going to split this lecture into 2 majors. The first half is about urinary incontinence. The definition of the urinary incontinence is defined simply as the involuntary leakage of urine. Thus is any urine leakage that the patient did not intend. The prevalence increases with age, as you can see at the bar graph that the prevalence is rising in older age group, and it's more common in older women than men, about 1.3 to 2 times. The prevalence in community dwelling shows somewhere between 15 to 30%, and the record at our clinic is about 25%, which is aligned with the community prevalence. And if you look into the prevalence at homebound elderly or nursing home residents, the number jumps dramatically to 50 to 70%. UI has many impacts of patients' life. It can cause consequence problems, like for the physical domain at that area because of urine leakage. The skin constant moisture, so it increases of skin breakdown, increases of skin infection, urinary tract infection, and because of patient need to go to bathroom quickly, they rushing to the bathroom, so it can increase of fall, consequently increase of fracture. And for the psychological, they might feel embarrassed and fear of urine leakage when they go to outside, so it can affect them by decreased activities, decreased self-esteem, overall decreased quality of life, and it might increase risk of depression and social isolation. And for the social domain, caregiver burden can increase the long-term care, and increase the substantial economic cost to the healthcare system. Given how common and how impactful UR is, and given that it's chronically underreported, patients are often embarrassed or assume it's just part of getting old. We recommend annual screening for all older adults. You can use open-ended simple questions that invite disclosure. For example of screening question, have you had any problems with bladder or urine control? Or do you ever leak urine when you don't want to? Or simply like, tell me about any problems you having with your bladder. These open-ended prompts give patients permission to talk about something they might otherwise never bring up on their own. Let's see the normal maturation. Because understand this is essential to understand why things go wrong. As you can see the picture on the slide, the urination is a highly coordinated process that involves the cerebral cortex here, the brainstem, spinal cord, peripheral nerve, receptor, detrusor muscle, sphincter, and so on. This all working together. Look at the brainstem. In the palm, there is the pontine micturition center. It serves as the central switching center that coordinates bladder emptying. And at the cerebral cortex, here, provide conscious awareness of bladder filling and voluntary control over micturition, allowing us to separate the voiding reflex until it is appropriate to urinate. Let's zoom in the storage phase. I try to explain step by step. The goal of this phase is to store urine at a low intravesical pressure while maintaining continence. When the urine fills in the bladder, as the bladder gradually fills, stress receptors in the bladder wall are activated. So it sends the signal through the pelvic nerve to the S2 to S4 level and ascend the signal to the periaqueductal gray in the midbrain, relays information to the cerebral cortex. This is what gives rise to the conscious sensation of bladder filling. When we determine that it is not yet an appropriate time to void, it continues to inhibit the pontine micturition center. During this phase, descending pathways actively promote urine storage. First, it promotes urine storage through the sympathetic outflow via the hypogastric nerve, and it activates beta-3 receptor at the detrusor muscle, resulting in relaxation of detrusor muscle. At the same time, it activates alpha-1 receptor at the internal sphincter, resulting in contraction of internal sphincter, so we can keep urine in the bladder. Moreover, the pudendal nerve arising from S2 to S4 contract the external ureteral sphincter, so we can voluntarily to hold urine by contract the external sphincter. So, the storage phase can be summarized in one sentence: sympathetic and pudendal on, parasympathetic suppress. Again, in the storage phase, the detrusor remains relaxed, the ureteral outlet stays closed, and urine is stored comfortably at a low intravesical pressure. Next one, the voiding phase. Absolutely, the goal here is exactly the opposite to the storage phase. The purpose is to empty bladder completely. Okay, starting from as the bladder coming more distended, so the afferent signal from the stress receptors become progressively stronger. This signal again travel via the pelvic nerve to the spinal cord and ascend to the periaqueductal gray, relay the information to cerebral cortex. And then the cerebral cortex created a strong desire to void. When we determine to void, it released or removed the inhibitory control over the pontine micturition center and allowing the PMC to coordinate bladder emptying. As I mentioned earlier that the PMC serves as the central switch to empty bladder. Okay, when the PMC is activated, it activates the parasympathetic pathway via the pelvic nerve, and then acetylcholine binds to empty muscarinic receptor, causing the contraction of the detrusor muscle. It also suppresses sympathetic outflow by inhibit via the hypogastric nerve and inhibit beta-3 adrenergic receptor and alpha-1 adrenergic receptor. So this resulting in contraction of the detrusor muscle and relaxation of the internal sphincter. You can notice that it's totally opposite from the storage phase. And the last one, because we want to void, so it inhibits the pudendal nerve, so it's resulting in relaxation of the external sphincter. So the bladder is contract, the sphincter is open, so we can void. Yeah. So the voiding phase can be summarized in one sentence as parasympathetic on and sympathetic and pudendal off. You should remember that the first desired to void typically occurs at a bladder volume of about 150 to 350 milliliters, while the normal functional bladder capacity is approximately 300 to 600 milliliters. Under normal circumstances, most adults void every 3 to 4 hours during the day. Now, I hope all of you understand the physiology of storage and voiding. So let's think, what does a person need to remain continent? Absolutely, we need an intact cognition, because cerebral cortex and cognition is need to recognize bladder feeling, understand the urge to void, and make a decision about when and where to urinate. And the entire micturition circuit should intact, from the cerebral cortex, brainstem, spinal cord, peripheral pathways, receptor, and so on. This all should function normally to coordinate between two phases. And then we need a healthy lower urinary tract, because the bladder must store urine at low pressure, and the sphincter and pelvic floor must maintain adequate outlet resistance. And we need adequate mobility and physical function, because older people need to reach the toilet safely and in time. And finally, we need an appropriate environment. A toilet should be accessible, nearby, clean, and free of physical barriers. So, a patient may become incontinent because of cognitive impairment, impaired mobility, environmental barriers, lower urinary tract dysfunction, or any disorder of conducting system, or more commonly, a combination of these factors. That's why our assessment shouldn't focus only on the bladder, it should assess the whole people. So what happens when we get older? This slide summarizes the physiological changes that occur with normal aging and explain how they increase the risk of UI. Before we go through each organ, I would like to emphasize that UI is not a normal consequence of aging, but aging reduces the functional reserve of this system. It making older people are more susceptible to incontinence when they faced with additional factors. Let's start with the brain. There is reduced cortical inhibition and altered central sensory processing. As a result, inhibitory control over the micturition reflex become weaker, predisposing older people to urgency and urge UI. What about the bladder? There is increased collagen deposition and decrease in smooth muscle in the bladder. Taken together, is decreased bladder compliance, so it can lead to frequency and urgency. And detusser overactivity also increased, resulting in involuntary bladder contraction, leading to urgency or UI. And reduced detusser contractility, which implies bladder emptying, increase the post-residual urine, and predispose to overflow incontinence. Moving to the urethra and pelvic floor. Aging reduces the maximum urethral closure pressure, the urethral vascular cushion, while pelvic floor muscle become weaker. Together, these changes reduce outlet resistance and increase the risk of straight UI. Finally, the kidney reduce renal concentration ability together with blunted nocturnal ADH secretion leads to nocturnal polyuria, which contributes to nocturia and nocturnal incontinence.